Well, good morning, everybody. And what a lovely sunny morning it is today. I hope some of you had a chance to walk possibly through the lovely grounds here at the university. A particular welcome to those of you who are joining us today who weren't able to come yesterday. We had a fabulous day yesterday. Well, I think we had a fabulous day yesterday. And I'm sure we're going to have another great day today. Just a couple of housekeeping things. There's no plans for a fire alarm. If the fire alarm goes, the usual thing, we drop everything and get out of the building. The main assembly point is out that way, so go out through the front door there. For those of you who haven't spotted it, the toilets are fairly well hidden, but as you come in through the main front door, you look to your right and turn right, and they're down there. Yesterday you were all brilliant at timing, and I do hope that you'll continue with that again today. Oh, sorry, yeah, for those of you new today, I'm Adrian Freeman, beg your pardon. What I'd like to do now is to hand over to Professor Jean McEwen, the Vice Dean for Education at our medical school here, who will introduce our speaker.
Thank you very much, Adrian. It's a great pleasure to be here in a forum that brings so many international as well as regional and national contributors to the programme here. And it's a delight to see Eric Holmboe here. Now, those of you who were present yesterday would have seen his being presented with Honorary Fellowship of the Academy of Medical Educators, and will have heard the extensive and very impressive citation that we heard there. So Eric is currently the Senior Vice President with, and I have to say this carefully, the Accreditation Council for Graduate Medical Education, but he has a long portfolio of excellent work in medical education, including serving as Senior Vice President on the Board of Internal Medicine in the United States. And he has current work with the University of Yale Medical School and also with the Uniformed Services University of the Health Sciences. That's a pretty impressive university title. One of the things, however, though, is that I can bring some personal experience of having done a small piece of work with Eric some 5 years ago, because we originally met at the Harvard Massey programme, where I was an embryonic facilitator on the programme in 2011, and Eric was one of my scholars in my tutorial group. So you can imagine that was pretty scary. However, what I can see is, as well as all of these titles, Eric, as a general physician, is also a very skilled educator, and as a member of my small tutorial group, he was absolutely fantastic at bringing out the very best from our very international faculty, which included a professor from a medical school that was in one of the frontier towns run by the drug cartels in Mexico, right on the border of the US. We had somebody from Nepal who was running an embryonic medical school in a really quite remote and resource-challenged environment, and someone from Brazil who brought a completely different perspective from the Latin and Southern American perspective. And Eric was really good at making sure that everybody had their voice, and he was really good at making sure that I was sort of mentored by the pupils. So that's a great model to build upon. So very many thanks for coming to join us today, Eric. Delighted to see you here, and we look forward very much to this presentation.
Okay. Well, first, thanks very much for the kind introduction, and it's really exciting to be here. Some of my heroes are in the room, almost too many to count. I met Leslie Southgate roughly 12 to 13 years ago, and my life was never the same after that, right? Anybody who meets Leslie is always impacted by her wisdom and grace. Case obviously has been a leader that I've looked up to for a long time. I use his utility index on a regular basis, so it's really enjoyable to be here. What I want to do is try to talk more around the outcomes. We've really had some wonderful presentations already, and I've been playing with my presentation as a result of all the wonderful things that we've heard already, and I really hope to build on that. But I want to start with a story, because I think it's really important to remember why we're here. So let's talk about Mary. Mary is a 77-year-old woman with a history of heart disease and recurrent lung cancer who was recently diagnosed with bronchitis. Mary has made it clear she doesn't want additional cancer therapy. Despite several courses of antibiotics prescribed by 3 different physicians, all of whom are board certified and pass psychometrically valid exams, Mary feels worse, having to stop frequently to rest and catch her breath. Mary is very frustrated with her oncologist and primary care physician because, quote, they just aren't listening to me. I feel more tired and short of breath, and they don't seem to talk to each other. Finally, the primary care physician orders a chest CAT scan that shows her cancer has advanced with now bulky mediastinal adenopathy. The primary care physician refers Mary to a surgeon to perform an endobronchial biopsy to, quote, guide possible palliative therapy. Mary is confused about the need for the biopsy, having previously declined additional therapy. After 8 weeks of multiple physician visits with 3 physicians, Mary can barely get out of bed and has lost all appetite. Her elderly husband and children finally intervened independently and instituted home hospice directly. On initial hospice evaluation, Mary is severely hypoxic and confused. Oxygen medications are finally ordered for comfort and to reduce the anxiety from her shortness of breath. Mary dies at home 7 days later. The biopsy was never performed and none of her physicians were engaged in her hospice care. So, what I'd like to do is have you talk for 2-3 minutes with a partner about the following questions. Have you ever experienced this kind of care with a family member as a healthcare professional? How could a competency-based approach have better prepared Mary's physicians to better care for her? How could assessment have helped Mary get better care? So spend 2 to 3 minutes with a partner just contemplating these questions, okay? Let's go ahead and regroup. So Mary's going to be our touchstone for the rest of this talk, okay? So as we think about Mary's story, what are the most important outcomes? And more importantly, how are we doing? How are we doing as our various professions? So in the States, we use something called the triple aim, and there's various versions of this across the globe. You certainly have yours here in the UK, Sweden, etc. But I think this is just a helpful framing about why we're all here, right? No matter what role you play in medical education, this is it. This is the target. It's to improve the health of populations at reasonable cost and to make sure the experience of care by patients is safe, effective, patient-centered, efficient, timely, and equitable, right? These are the goals. This is what we're preparing people we hope they'll be able to do for the benefit of those we serve. Healthcare is a service profession, right? So this is the most recent report from the OECD on England, just came out. England should be proud of many things, as the preamble shows, but they did have some recommendations for this particular system. And you'll notice at the bottom, one that really stands out is something that was very much experienced by Mary, or not experienced well. Focus on quality at the interfaces of care, as well as on community-based services, right? Now, I can put these up because I come from the country that's the poster child for how not to do any of the triple aim, right? So I can get away with this. But it is kind of important to think about, what are we trying to accomplish? And each of us in all of our countries have challenges with regard to quality, safety, and those experience of care issues. This is from the Commonwealth Fund. This compares kind of care coordination. These are basically follow-up after a patient's been seen in the ED or discharged from the hospital with the primary care physician. You can see that the Netherlands is actually doing the best on this particular comparison. UK's third, but obviously lots of room for improvement, and we're about somewhere in the middle. And this is a real problem, right? This care coordination is a huge issue, and it takes skills to be able to do it well. This is a study that I was involved with where we looked at the quality of care among older adults that were being seen in internal medicine and family medicine training clinics. And as you can see, for all of these particular quality metrics, none of them exceeded 40%, right? So the question I'd ask you, the kind of gut check, is does anyone really want to take their older parent or grandparent, assuming you love them, to a clinic that provides evidence-based care for less than 40% of the time? Do you really want to do that? More importantly, perhaps for us today, do you really know if your learners are providing and your patients receiving high quality and safe care in the training setting? And as I'll show you in a minute, does it matter? Should we really worry about that? Well, we're teaching the right stuff, right? We're giving the right knowledge, stuff like that. Does what the experience matter? We'll come back to that. So that brings us to, so why competency-based medical education? Why has it become such a driving force? Well, I think we've lost sight of it a bit, to be perfectly honest. And it goes back, I think, to this wonderful report from 1978. The first author was a gentleman by the name of Bill McGahey. Some of you may know his work in master-based learning and simulation. Bill was a young medical education researcher at the time. And you'll notice that second name that you saw yesterday from Case, that guy named George Miller, some pyramid that he developed. But what they said about the need for a competency-based system was in the preamble of this report. The intended output of a competency-based program is a health professional who can practice medicine at a defined level of proficiency in accord with local conditions to meet local needs. In other words, it's about who you care for, right? That's the driving force that should be behind medical education. And more recently, a group of educators and policymakers in the Lancet in 2010 got together to kind of revisit why we should be thinking about this model. What they pointed out in the last 100 years, that we were heavily driven by this focus on curriculum from experts. Not a bad thing. If you go back 100 years, we know that many of our curricula that were being promulgated by schools weren't terribly good. And the structure that came with some of the work 100 years ago was very important. The problem is it kind of got concretized. And so you have this kind of curriculum. The 2+2 model really took hold in the States and Canada, for example, and we wrote lots of educational objectives. Just out of curiosity, how many people have written an educational objective? Yeah, how many people actually find that they end up mostly on the shelf? Yeah, right, we write lots and lots of objectives, we might assess against them, and that assessment was mostly knowledge. But what Frank and the group pointed out is that, again, much like what the World Health Organization report had talked about 32 years earlier, was that it had to start with the health and healthcare needs of the systems. And the competencies and outcomes should flow from those. The competencies serve as the framework for the educational outcomes or abilities, and the outcomes should really be driven by what the patients need. And they change based on new diseases or globalization. I don't have to remind anybody about the Ebola outbreak and how tragic that was, and how quickly that spread because we no longer really had this kind of systems to deal with it once it got into urban areas. It had always been kind of something that happened out in more rural areas. And then finally, the one thing I don't like about the slide is this idea that somehow curriculum and assessment are separate. I think they have to be integrated, right? We talked a lot yesterday about assessment driving curriculum, but it has to be the right kind of assessment. But curriculum should also drive what's the most appropriate assessment. And Case talked a lot about progress testing linked to the curriculum and the blueprint to make sure that people are getting what they need. And I think that makes a lot of sense. So let's talk about where we've been in assessment. We go back to the 20th century, really from the time of Abraham Flexner, again, who was very influential in the US and Canada, really into the 70s. It was really dominated by the testing of knowledge, right? And a lot of good work came out of that. Psychometrics matured as a scientific discipline, and standardized testing became relatively standard for selection, licensing, and certification in many countries. And I know you're talking now about a national license examining here, and they had utility. You know, they served a purpose. We also had the rise of the importance of clinical skills and soft skills. By the way, I absolutely hate that term, soft skills. Really? Soft? We'll come back to that. Such as communication. And then the rise of the standardized patient, particularly OSCE, you know, the work of people like Ron Hardin and others. And they also became part of licensing exams. And so again, many licensing exams contain this component, and there's been real value in that. It's called attention to the importance of these skills. During the 20th century, the faculty really important, and there I think we've struggled a bit. For most of the last century, really up until about the 1960s and 70s, faculty spent a lot of time at the bedside. And so they really did a lot of role modeling, spent a lot of time with learners, but then through specialization and other forces, they began to egress, particularly as the research enterprise took off. For us, it was the National Institutes of Health in the 1960s, really changed everything in academics. And so there's been this egress away from the bedside and actually a lack of direct observation to the point now that when it occurs, it feels foreign to students. Like, oh, it's such a pain to get observed, as if somehow it's an intrusion or feels high stakes all the time. And that's unfortunate, I think. So as we think about the assessment pyramid and where we kind of were as of 1990, it had really been dominated from an assessment perspective by the nose to show how level, right? We'd really begun to understand the testing, it had really become sophisticated, and then the rise of the standardized patients and growing simulation had really moved us forward. But here's the bottom line, they're proxies, right? And there could be important proxies, but they don't tell us what actually happens. Right? We assume if they do well in here, it translates or transfers into the setting where they actually take care of patients. And I have no trouble with proxies, but we have to recognize them for what they are. That they basically give us a sense of capability or capacity. But they don't necessarily tell us what's going to happen or what people do. And yes, you cannot function with an empty hard drive. This is probably our best American export, Homer Simpson. We'd like to export some other things currently, but I'm not so sure it would be welcome. But you have to understand that what's on the hard drive just isn't enough, and we're beginning to really understand this. This is actually a study that I really enjoy. It was a review by Delfoy and colleagues about how often clinicians in their daily work, these aren't trainees, these are practicing clinicians, encounter a clinical question for which they don't have at their fingertips, but if they knew the answer, they feel would help their patient. And you can see it's stunning. So on average, a clinician will encounter a clinical question about once in every 2 patients, right? Think about that. So if you're seeing 20 patients in a day, you're going to encounter 10 questions that you don't have on your hard drive or the tip of your fingers that you really think you need to know. And so, you can just kind of break it down. I'm a general internist by training. These are very conservative numbers, but you can add this up that over a 10-year period, you're going to encounter 22,000 questions in the course of your daily work, right? Think about that. No 300 or 800 question exam is going to take care of that. It just isn't. And what's more sobering is that physicians of of these questions only pursued about half of them, as you can see. These are the range from the studies. And then they were only able to actually find answers from about 3/4 of the time. So you can see the voltage drop and how much stuff may go unanswered. Now, many of these may have not been serious or, been relatively minor, and they might get filled in later. But it goes to show you the challenge of practice today. There's just only so much you can cram into somebody's head. And we're going to have to teach this as a skill, right? Be able to find information, clinical decision support, looking stuff up, etc. This is another study we did where we actually audited 236 general internal medicine practices across the United States. And on average, we audited about 100 charts per practice. So in the end, we had nearly 23,000 charts that we had abstracted, and we looked across 46 different performance measures, from chronic care to prevention to acute care. And we also took a look at the nature of the practice. And as you can see, a range across physicians with regard to age, the gender, the ethnicity they cared for. The ranges are stunning. Here's the bottom line, right? Just looking at the demographics from the study. If you've seen one general internal medicine practice in the United States, you've seen one, right? They're so variable in what people care for. How do we prepare people for that world? Here's the other part that was pretty sobering. So you can see these are box plots across all the conditions that we abstracted, and these are the aggregate measures per condition. And you can see that the interquartile ranges for some of them are quite wide, and the overall range is, it can be quite stunning. We actually then took a look at these composite measures that we had developed, and then we basically looked to see how they correlated with the maintenance of certification exam, the knowledge exam, which is a 180-question test that's given every 10 years. And they did correlate, so that's good news. There's some validity evidence, but here is the sobering part. The exam only accounted for 4.9% of the variance of practice. That's it. So if you think about that exam as a proxy, it's basically not telling you about the other 95% of what's going on, right? So it's not an either or. It's not the exam doesn't have value, but when you think about it from a practice perspective, you see this kind of variability. You have to ask yourself, what is the best type of assessment? Where do we want to go? And then finally, just to show you how complex it is, kind of keeping with the general internal medicine theme, this is one of my favorite studies from Cynthia Boyd. I think it's now been cited 1,000 times. But she looked at all the clinical practice guidelines to see whether or not they address the issues of comorbidity and trade-offs. Because many older patients have multiple conditions, and so, you have to make trade-offs. And very few of the guidelines made any mention of these trade-offs. And so what they did is they created a hypothetical 79-year-old woman with these conditions: COPD, type 2 diabetes, osteoporosis, hypertension, and osteoarthritis. Pretty common combination, right? And this is what would have come out if they had simply applied each guideline that applied to these conditions. All right, this 79-year-old woman would have required 12 new medications. She would have had to engage in a complicated non-pharmacologic regimen. And oh, by the way, some of her medications would have likely interacted with each other and called adverse interactions. What physicians do is they work with these trade-offs, right? There isn't a test question that gets at this. That's the other point. So this is where judgment in assessing how well people manage these trade-offs is really important. And so you have to ask yourself, is high-stakes testing, become part of normal science, and what are the implications, if we're not careful? And I love this book from Thomas Kuhn, The Structure of Scientific Revolutions. I think it's just a stunning book and is held up over time. And he said the following: normal science, the activity in which most scientists inevitably spend almost all of their time, is predicated on the assumption that the scientific community knows what the world is like. Much of the success of the enterprise derives from the community's willingness to defend that assumption, if necessary, at considerable cost. Right? So as we think about moving forward in assessment, we have to be very careful about this. This is where the concept, by the way, of paradigms came from. It was Thomas Kuhn's book. And I think, it's one of the things we get locked into our paradigms, and it's very hard to let go. It's hard to unlearn things. But as I think we think about 21st century practice and the complexity that I've just shown you, in Mary's case, the Boyd study, and the study that we did, some of our older approaches just aren't going to cut it. And that's okay. That's not a bad thing. It just is a recognition that maybe we need to do things differently. So this has really been the sources of discontent if you're a policymaker. My background actually is mostly in health services research. That's where I did my training. I spent a lot of my early part of the career looking at quality and safety, and so working with these policymakers, this is their discontent with the medical education system. First is that there's this rapid expansion of medical knowledge, and you just can't carry everything in your head, as if you really ever could, right? It may have been a misnomer in the first place. Escalating complexity, aging populations. Everyone in this room in your countries, I know, is facing what we call in the States the silver tsunami. That would be me. Increasing burden of chronic disease, recognition of uneven quality and safety in the way we deliver care, and of course rising healthcare costs is a concern for all. And I know it's a concern here in the UK. So this is our new reality. You know, medical knowledge of human function disease is still important, right? But what should be on the hard drive, I think, is becoming more and more of a challenge, right? What's enough? And if the purpose of testing is to basically distinguish or discriminate between trainees, you know, is that going to work when it might be more important to test what's most important in common for what the population needs? There's a tension there. Right? I think the predominant use of proxies is really no longer sufficient. They still play a role. They're important, particularly from a developmental point of view, but they're not going to be sufficient if we really want to get at the DUS level. And we know that medical care involves a lot of other stuff, other knowledge, and that's something that Case alluded to yesterday in his talk around programmatic assessment. All right, so where does that leave us? Well, I think one of the things we need to do is reframe assessment around the patient. I think what's happened is we treat the patient as an object, something to adjust out of our assessment equation instead of being the subject. What do I mean by that? So this is an article from Brian Wong that I think is really helpful, and I think part of our problem is we've seen educational and clinical outcomes as something that are separate. They're kind of distinct, right? And in fact, many of our learners get frustrated when they're so busy with clinical care, they say, I'm not getting enough education, because in their head, education is conferences, morning report, attending rounds, whatever that may be. In other words, it's something away from the bedside, right? That's really unfortunate, but that's kind of what, in the sense, we've created in the States. Oh, and that clinical care stuff I do over here, yeah, that's important, but that's service, I'm taking care of people, and so, you know, they don't really connect. And I think there is this kind of divide, and sometimes you actually see it show up in things like, you know, talks like patient versus education. Really? Versus? Right? Isn't this why we're here? Shouldn't they be an and, patient and education, or patient and learner? I think we have to be careful about that. Because what happens in the clinical space is actually the most impactful aspect of care. And I'll come back to that in a minute. And what we really need, I think, is this. Right? We should be focused around the patient, right? You start at the end in mind. What does this patient need, and then work back? What are the knowledge, skills, and attitudes, competencies, whatever framework we're going to use, needed to care for that patient? What are the system effects that get in the way or help in caring for that patient? Yeah, it's complex and it's messy, but at the end of the day, we need to bring these two worlds closer together. And it's been interesting to watch the medical education research community and the kind of health services community running in parallel, yet so much of what they're trying to solve actually overlap quite a bit. I also think that when we think about the patient, it reframes the way we even observe. This is an equation that Jen Kogan developed where you start with, did the patient get safe, effective, patient-centered care, and work back. Right? You don't start with like, well, how the trainee do? Like, well, you know, it was a really difficult patient today, so I'm going to cut him some slack. It's probably okay. You know, I think it's still probably pretty average, even though the patient didn't get what they needed. Does that really make sense? Or do we start with what the patient did or didn't get and then work back? How much of it was due to the trainee's performance? How much of it was system factors? Because those system factors are important sources of feedback. And then what supervision is necessary to make sure patients get good care at the same time I'm making sure my learner is developing appropriately, that they're picking up the skills they need. And then how does it also fit within collective competence? Because we don't work in isolation, we now work in interprofessional teams. And all this matters. And here's probably the elephant in the room, and here's a caution about this, all variability is good. I actually do not agree with that. That if your attending lacks clinical competence and applies that to that patient, that is not good variability, and that is not what we want to treat trainees. There's a real danger there that we're going to say anything goes. No, not everything goes. Because we have to think about the patient and what we've learned in our work, and we know from the health services world that the scary part is many of our faculty do not have the kind of skills they really need to teach these things well. They just don't. And it's not necessarily a fault of them, but we need to help them gain some of those skills. And I'll come back to that, because think about Mary's care, right? Right? Think about that. Does training environment affect practice? I've been alluding to this. Yeah, I think we're now developing evidence that shows how profoundly impactful it is where you train. The more recent study that got a lot of attention was David Ash. He looked at the complication rate of major obstructive, or the rate of major obstructive complications at the hospital level, how the institution was doing. And then he correlated that with how graduates from that hospital's training program did out into practice. And he found a direct correlation. And the relative risk difference from the top to bottom quintiles was 32%. Now, here's the other scary part. That effect lasted up to 19 years. The bottom quintile never catches up to the top quintile. The good news is they get better, but there's always a gap, right? Candace Chen looked at this from a cost perspective where you trained. If you trained in a high-cost area, you stayed a high-cost provider, even if you moved into a low-cost region. How long did that effect last? 16 years. Sirovich, we did a study with Dartmouth looking at how you perform on exam, where the right answer on the test is do little or do nothing, right? And then we looked to see if they trained in a highly intense environment. And one of the measures we used was the number of visits a patient experienced in their last 6 months of life. Think Mary. Guess what? If you train in a high-intensity area, you do worse on those questions on the exam. And when I was at Yale, I used to hear things like, well, you know, Eric, we wouldn't do it that way here at Yale, but this is the right answer when you take the certification exam. Well, that may not work. That may not be a great strategy, right? And then Bansal recently shown the same effect with surgical complications, similar to Ash. And then 20 years ago, Robin Tamlin showed this effect with even prescribing patterns among medical students. So what your trainees experience, the quality that they deliver, you know, along with you in the institution matters. And it shouldn't surprise us. This is work from Paul Batalden and Frank Davidoff. This comes again from the quality world, where they point out that in order for everyone to benefit, to get better patient outcomes, we have to engage the patients, but we also need better professional development as part of our routine activity. It's not just we educate here and then, you know, we do something every once in a while. This should be what our daily work looks like. And so we have better system performance, better professional development, better patient outcomes, and when we strive to bring those things together, everybody benefits. Education's no different. So assessment, where do I think we need to go? So going back to our Miller pyramid, I think we have to spend more time at the top of the pyramid, or, you know, as Case pointed out, and I think Leslie's talked about, invert the pyramid, right? Think more about the does. It's hard, it's messy, it's a younger science, but that doesn't mean we shouldn't go there. Right? And let's face it, work-based assessment is mostly accomplished through the observations and questions of faculty, team members, peers, patients, and other coworkers. Those are the two primary methods. How we capture them, you know, I think can certainly be helpful, whether we use EPAs, milestones, I'll show you in a minute, but this is it. This is the two predominant methods. The question is, how do we prepare people to do this well, and how do we make sure that things we're asking are useful to help our learners grow professionally? How many people have ever read this article by Atul Gawande, a surgeon at Harvard? It's written books like the Checklist Manifesto. I strongly recommend this. He's an endocrine surgeon. He was looking at his morbidity data and realized he'd kind of plateaued. He was a bit disturbed by it. So he asked a mentor to come in and actually watch him during a surgical procedure. And during that surgical procedure, he said the following as a result of the coaching he got from that individual. They observe, they judge, and they guide. That one 20-minute discussion gave me more to consider work on than I had in the past 5 years. Medical practice is largely unseen by anyone who might raise one's sights. I had no outside ears and eyes. His point was, in medicine, we don't do very much of this after we leave our training space. And yet he learned so much from just that 20-minute conversation. And a lot of it, by the way, was highly specific or reductionistic. It was like where he was holding his elbow, where he was standing at the head of the table. He was blocking the field of some of the assistants that were working with him. All these refinements. And this is something that, you know, Chris Watling talked about in his wonderful article comparing, you know, kind of athletes and musicians and the kind of coaching approach versus what we tend to do in medical education. And this is just a nice personal description. Now, there's a rumor he did get a little bit of grief from another set of health professionals about this article. Anybody guess who those health professionals might have been? That would be the nurses. They said, like, we could have helped you. We spend a lot of time with you in the operating room. You may have noticed. Yeah. Like, that where you're standing bit, yeah, we could have been helpful, right? And so we tend to forget that, there are multiple sources of feedback that we can use, and sometimes they're right in front of us and we just don't recognize it. This is something that Case also brought up, and I totally agree with, that we've set up a lot of dichotomies in medicine I think are just false, and not only false, I think they're unhelpful. They're often set up as either-or arguments when they really should be set up as kind of polarities, and I'll talk more about that in a minute, but you add to your own list here: checklist versus global judgment, reductionist versus holism, qualitative versus qualitative, flexibility versus standardization. I talked a little bit about the variability, how we have to be careful with that if you're from the patient perspective, work-based versus standardized, you add your favorite one. I think we have to rethink this, and this is really wonderful work from Barry Johnson, who's been writing about this for years, this idea of rethinking polarities as an and, both and how to do that. And this is what he calls his polarity map. And so at the top are, on both sides of the poles, are the benefits and the action steps to using the two poles effectively, and the bottom are things that are kind of unintended consequences, early warnings, and things you want to avoid. So for us, we talk a lot about reductionism and holism. There are times where reductionism makes sense. There are times, for example, when you use a checklist, if used well, does make a difference and actually can be really helpful. But there's just other times it doesn't, or sometimes you need both. But I think our goal is honestly to improve med ed, and therefore patients and populations benefit. And what we want to avoid is the extensive work and expense that really doesn't help us and just creates frustration. And the kind of tick box exercise that, again, was talked a lot about yesterday. And so I think part of our challenge is that we've kind of been stuck with no way to connect these two. So again, kind of going back to the case of Mary, one of the things we know that there is a framework called spikes that can be very helpful in breaking bad news to patients. So when you got to break bad news, there is a way to structure that conversation that's been shown to be helpful. It's not that you follow the recipe, but using this framework can be very useful for both trainees, but also physicians. Because, by the way, practicing physicians don't do this well. If you look at all the literature on the effectiveness of practicing physicians to break bad news, it's pretty sobering, right? Because it's a hard skill. It's emotional and it's difficult, and most of us were not taught any formal way to do it. I wasn't taught this. I had to learn this later. It was never part of my training. It was basically, well, Eric, you're the second-year resident. I think you need to go talk to the family because I think it's really time to take Mrs. Jones off the ventilator. Okay, I'll go do that. Wait a minute, how am I going to do that, right? So that's not really very effective. And what we really want is effective end-of-life counseling that meets the patient and family needs. We want that holism because that's the outcome that really matters. We could check all these boxes off and not achieve that goal. And so there's a concept out of mathematics that I find very helpful called combinatorial optimization. It's very similar to the optimization that Case talked about. And what the real question is that what's the right combination for this patient in front of me? What's the flexibility needed? I can use this framework, but I got to meet the patient's needs. And I actually think the good news is that this requires judgment. We have to have shared values, have to have skills, but we have to use judgment. There's just no way to get around this. And it's not a bad thing, but we have to teach people how to do this well. And through experience and practice and coaching, people can certainly pick this up. So the other thing we've really struggled with on all of our competency frameworks is how to make sense of them. And these are just some things that are beginning to happen. It's still, the jury's out, to be perfectly honest. We don't know if these will help, but I'll just simply cover them a little bit to give you a sense of what some systems are trying to do. In the States, we're using milestones, right? We had a hard time operationalizing our competencies, particularly the practice-based learning and improvement and systems-based practice, which really target those other skills that you need in 21st century practice. And so we basically heavily built ours on the Dreyfus model. It was fascinating looking at Case's talk yesterday about the 5 levels in the communication. They line up almost perfectly with Dreyfus. It shows you that there really is probably some commonalities here. And for us, the goal at the end of training is level 4. It's a recommendation. It is not a requirement. It's meant to be formative, to provide a blueprint blueprint in words about what somebody should look like at the end. And like I said, these are far from perfect, but at least it's beginning to use language in words instead of like trying to assign a number. We do not put PGY years, postgraduate years, on these. There's strictly levels, based on Dreyfus. And this is just kind of the anatomy. So we break the comps down a little bit. There's roughly 20 of these per specialty, and then we use words to describe what each milestone or level looks like. And we're agnostic to what year of training they're in. As you know, EPAs are also very helpful. They're getting a lot of traction. Whereas competencies describes the abilities of the individuals, EPAs describe what you do, the actual activities. And the concept of entrustment, I think, is really important. It's making more explicit what has been frankly implicit, right? We've used this for a long time. We just haven't had a language around it. So I give Ola and his colleagues a lot of credit for adding to this language and understanding about what this means, what these activities might look like. As I said, we use the Dreyfus model development. This is, just what it might look like. Learning curves actually tend not to be linear. What's interesting, the reason they're probably linear for us in training is that we're on the steep part of the curve. So as you move from novice to kind of competent near proficiency, if you look at the learning curve literature, Martin Pusik's written a very nice article on this. It actually does look pretty linear, but on the ends, it's not so much. It's more sigmoidal, actually. And the reality is, if you don't keep working at it, you don't keep getting better. We know that from the literature. In fact, there is a decay curve that can often occur among physicians, and those who work in solo practice, at least in our setting, are at the greatest risk for that. And I think this kind of modeling and thinking about it in a developmental fashion, as Case talked about, also gets us out of what I call the ballistic model of competence, where you hope you launch somebody so high up into orbit that they retire before they burn up on reentry. Just not a good strategy. And so we know that people have different trajectories. And so as Case talked about, that person in red, unless you can intervene and readjust them quickly, they're just not going to make it. And it's better that we move them into something else instead of have them passed along. We have a big problem in the States with failure to fail. I think part of it is by the time they reach medical school in our context, they've had 4 years of college, they're already significantly in debt, they're paying a lot for medical school, and there's this reticence to let them go. In some respects, if you're 18, 19 years old and you're not going to fly, it's probably good to find out earlier so that you can readjust with probably less consequence. That's a real challenge for us in the States. We don't have that. But this is actually what we're seeing with some of our milestone data to share with you real quickly. So this is the attainment of level 4 across all graduates in neurosurgery in 2014. And these are aggregated across the 6 general competencies. So in order for you to get marked as complete, you had to attain level 4 in all the subcompetencies within each of the disciplines. And what you can see is that for the 6 competencies in aggregate, none of them reach 100%. None. Right? So there are trainees coming out that did not reach the recommended target. And then the question becomes why? And for some of them, like patient care, only 54% of graduating neurosurgery residents actually attain level 4 in all 8 domains of surgery they consider to be part of their core curriculum. So your first reaction might be horror, like, oh my God, this is brain surgery. Are you kidding? Actually, this is ecstasy to me, because this demonstrates that we've got issues around curriculum and what's happening in the institutions. And we can actually break out by those domains where the discipline is struggling. There are many centers that just simply don't do enough peripheral nerve or epilepsy surgery to train people to a level of proficiency for unsupervised practice. I'm actually really happy they know that. I've actually talked to a number of neurosurgery residents. We have a paper submitted currently, and the residents say, like, oh yeah, I'm not going to do that. I barely did any of those cases during surgery. So then the question for neurosurgery becomes, so why is it part of your core curriculum? What do you want them to get out of it? Right? Why is it part of their requirements? And they're now having that conversation. They said without this data, they never would have had that conversation. They just would have bopped along, kind of doing their thing. So this is what happens when you have national data on stuff other than medical knowledge. Is it messy? Yeah, you bet. It's really messy. But it's creating the kind of conversation improvement we want to see. That's the goal of this whole system, right, is to improve care and improve education concomitantly. And this is what we're beginning to use the data for. I'd be less than honest if I said not everybody's real happy about it and having to do this, but I think if we can work together collaboratively, much like what you've talked about here in the UK, we do have the benefit of really helping to advance training in ways we haven't before by looking at these other competencies, the ones that Case highlighted highlighted, and we'll come back to. So here's where we are. I think the competencies define the core abilities. Milestones are a way to operationalize those, create a language instead of these scales. Even though it's kind of done at a level, at least it creates language. The residents, by the way, when we've done our focus group work with them, like having that language. It's not so much a black box anymore. They have a sense of where they're headed, and that's helpful. EPAs describe the activities, and so you put those two together, you need the ability to do the activities. They actually intersect quite nicely. And Ola's written a very nice article a year ago about how these line up, where you can actually create stories about where people should be along their developmental trajectory. And that's really helpful for faculty. But in the end, this is really all part of a system, and this is what it looks like in general across most countries. In our country, our accreditation activities are separate from the certification. They're done by different organizations. But at the end of the day, we need these licensing and credentialing functions of some type to ensure the public that people are coming out prepared for practice. But the bottom line, no matter where you are, is that what happens inside the institution, the program, is by far the most important thing. And that judgment piece matters a lot. And there's just no way to remove it. In fact, I'm not sure you would want to do that, right? Judgment matters. And so that judgment's critical because it's the program, the medical school or the postgraduate training program that ultimately decides whether or not somebody graduates, right? And in the States, the sobering reality is that if you graduate insufficiently prepared and you cannot pass your certification exam, but if you've gotten your licensing exam, you will practice medicine in the United States. It's just that guess who you're going to care for? You're going to take care of the poor, because that's where you can get a job. Right? So in our market-based system, the irony is we exacerbate disparities when we put people out into the system who aren't ready to do unsupervised practice. That doesn't feel good. And so inside the institution, there needs to be some combination of assessments, right? That programmatic assessment, and then you have to make sense of it. And much like what Case talked about, we now use a committee or group process, right? I think group process, when done well, is incredibly powerful. We call it the Clinical Competency Committee. The goal is to review progress at least twice a year on the residents, looking at all the assessment data, and then work with that resident to develop an individualized learning plan. Right, so that they can then guide their learning over the ensuing 6 months, based on the curriculum they're going to experience. What's interesting to me is we use a lot of group process even in high stakes, right? It's not like, you write a test in isolation. How do you do angoffing? Let me see. Oh yeah, that would involve a group, right? So we use group process all the time in assessment. It's just that we haven't thought about using it as much in work-based assessment, which I think has been unfortunate. And so the committee, when it works well, can be a very powerful tool. And we have some programs that are doing this very well, as you might imagine, some are struggling. But it's a major part of our system of assessment, right? It's part of the program is to have this group review and use good judgment to bring in the wisdom of the crowd, if you will, to make those judgments. I want to close with a couple thoughts. I also think that there's another concept that's gaining traction on the health services side. I think has great utility for education. It's called co-production. This is work by Maureen Batalden and her dad, Paul, in a group that just came out in the BMJ Quality Safety this past spring. And this concept of co-production is when we are caring for patients, particularly those with chronic disease, we don't do that in isolation, right? Patients co-produce health and healthcare with us. Think about all the stuff a patient has to do if they're managing their chronic disease. They don't spend most of their time in your office. They spend just a wee fraction in your office. Most of it's spent out in the community in their home. And they're the ones having to manage their care. So how do we co-produce with them to help them? And so how do we do that? Well, one, through civil discourse. Again, just referring to my country at the current time, seems to be in terribly short supply. Co-planning and co-execution are really important parts of that. And then we're embedded within a healthcare system and a community. But that can lead to co-produced high value. And probably the best story of this in the States is what's happened with cystic fibrosis, where the parents are incredibly important caregivers to their kids. And because of the advances made in nutrition and other things, these kids are living much longer now. They're actually seeing adulthood. It's really been a major success story. And a lot of it has to do because of this co-production process with parents who are critically important caregivers who do most of the care, right? They do most of the care. Well, we think about it from an educational perspective. We can just put in a learner there with patients or professionals, and we can see that learning is also a co-production process, right? We co-produce with our patients and our faculty in the process of learning. And so I think this co-production mindset is not a bad fit for education. I think we need to explore it, and it might be a way to bring these quality and educational worlds closer together in more functional ways so that both the patients and learner benefit concomitantly, so we don't have to feel like it's an either or. So I think these are the major trends. Developmental and competency base, I think, has been very helpful. We have a lot of work to do. It's painful, it takes time. There's a greater focus on connecting these education and clinical outcomes. You're beginning to see this work. Case is working with a very talented young educator in the States by the name of Daniel Schumacher, who's exactly trying to do this as part of his PhD. I think we're moving away from an over-reliance on psychometrically based assessments. It's not to say we shouldn't continue to use them. It's a balance issue. Again, it's not an either or, it's a both and what's the right balance. I think the concept of entrustment for supervision is helpful. We're beginning to figure out how to operationalize the competencies through milestones and EPAs. Much work remains to be done. They will need to change and evolve like anything else. I think programmatic or programs of assessment is critical. And then group process, I think, is really an important aspect that's been added back into the systems. And that, again, if done well, can make a big difference. So let me just close by saying, yeah, this all sounds great, but implementation is really hard. And I think if you look at some of the implementation science, there's now a whole journal on implementation science. This is really where I think we're struggling. And if you look at all the elements that it takes to implement something well, these are the elements you have to attend to. And a lot of what's happened with competency-based medical education is that we haven't really attended to these things very well. Partly because none of us are trained to do it. I was a program director in 2 settings. I wasn't trained to do this stuff. I didn't even know this stuff existed. And so I think we're going to have to help our educators figure out the importance of what implementation looks like and how to get there. Because what I worry about is somehow all this complexity around implementation got reduced to this: CBME equals a checklist. And yet when I show you the definition from the WHO and from Frank, that's not what they say. It's not even anywhere close to what it says. Mary didn't need a checklist. That would have been the worst thing for her. What she did need was a group of physicians with the better abilities or competencies in end-of-life communication, care coordination, diagnostic therapeutic reasoning, interprofessional teamwork around palliative care, and situational professionalism to better meet her needs and that of her family. Well, in other words, she needed those other competencies. Was knowledge involved? Sure, knowledge was involved. But boy, there's a lot of those other things that were involved that we now know are important. And her physicians didn't have them. They didn't have them. Oh, and by the way, they're in an academic health center. So this is the things that we think we're going to really need to focus on. And this is where work-based assessment is critical. And the work of the EBMA, I think, is really exciting to see what's here. When I was at Amy, I lamented in the last panel. I was a bit despondent because I walked around the conference for 4 days. I rarely heard the word patient. Rarely heard the word quality or safety. And that bothers me. And yet, that's why we're here. And I'm so pleased when I looked at the program here. There's a whole thing about patients. There's a whole workshop on patients. Right? There's a workshop on videoing, videoing with patients. I mean, that's just fantastic. So I can't encourage you enough to continue that important work. So this is where we are. I think competencies help make what's been implicit more explicit, and it makes us attend to things that we haven't. Quality, safety, care coordination, interprofessional teamwork. Those words did not exist in my lexicon when I was a resident. That was just 23 years ago. Didn't exist. They should, and we need them. Now, I'm not naive. I know there's no magic wand, and I am sitting here in the UK, so Merlin and I think Harry Potter are more than appropriate. That there's no magic wand or Holy Grail, and so is John Cleese, and I am not related to John Cleese, although some people think I am. But I think the goal is just to remember medical education is really to benefit both patients and learners. I don't think we want to lose sight of that. I think we can do a lot of good. There's an immense amount of expertise in medical education community. Bringing it together to both improve learning and care, I think, is really a huge opportunity. And since we're also sitting in England, we can do it, right? I think it's pretty cool right now. And I think we're going to need to use more of these co-creation, co-production approaches. And by the way, co-learning. And by that I mean our residents and our students are going to have to learn alongside our faculty, because for our faculty, many of them need to learn these skills too. And we're going to need to help them get those skills so that when they're doing the assessment, they're using a frame of reference that of high quality and best practice. So I will stop there and be really anxious to hear your comments and have a conversation. I think we've got about 20 minutes. Is that correct, Adrian? Great. So thank you very much.
So thanks very much, Eric, and a really thought-provoking topic there. And as part of those thoughts, sorry, a really thought-provoking talk there. And as part of those thoughts, I'm sure that's generating a lot of questions. And fortunately, we've got an expert to hand who could tell me how to operate the mic and run up and down the stairs. So, questions, please. On Caroline, on the left there. The lady just...
Just referring back to the slide you had with the holism and reductionism, the other way around actually.
Yep.
And you were saying how you didn't feel that you were necessarily taught how to handle breaking bad news. The one bit I felt might be missing, and I wanted to know if you could respond to this. I do break bad news. Maybe I'm not great. Maybe I'm okay. But there wasn't a bit about me in it. So I can only do this for about 10 minutes before I personally start crying, because I see everybody else crying and that's my reaction. So there wasn't anything about the culture of the... there seems to be for me something missing in some of this about the personality, the culture, and all of what me as a trainee or a clinician or whoever I am brings into the picture, and how that can be part of this.
Oh, yeah, I apologize if that didn't come through. I couldn't agree with you more. That's partly, if you go back to Jen Kogan's kind of equation, all that comes into play, right? Everything occurs in context, and you bring self into it. I think you bring up something that's really important. We don't tend to the emotion as much as we should. You know, particularly in these kind of skills where emotion's such a big part of it. We actually use this as one of our stations when we teach direct observation. One of them is the breaking bad news. And I know Peter and Marjan are here, who've been working with us and been just incredibly helpful. We have a videotape that we use, and the inferences people make often fail to acknowledge the emotion that might be going on inside the learner. So you're absolutely right, and I think you just have to go there. One of the things that I know Marjan and we found that we make a lot of inferences when we're watching trainees. I think one of the things that's important is to ask them about that inference instead of assume you're correct. And that actually helps get at the emotion, right? So if you really think they're uncomfortable, go there, because that's actually really valuable feedback. So I really appreciate you bringing that up, because I think that's absolutely a critical component of this. Yeah.
Sorry, Anselm,
Anselm from Belgium, Kent University. Hello. Thank you very much for a very inspiring talk. I would like to start with your line of thinking at the beginning. What should we have done differently to prepare trainees, residents better for the practice of the future? And then during your talk, I was thinking about we assume that we have a perfect professional environment and a perfect training environment, but it has the only task of helping a new trainee to acquire all those skills. But in fact, this world is not perfect. Like you said, we also need to learn as faculty. So we are in a transformation process of the training for family medicine in our country. And one of the things we want to do is to bring the learning of the residents closer to the learning of the trainers, because we know that there is a big variety of training practices, and they have their own training system, but often this is separate from the training of the residents. So that's one of our questions. How can we train residents in an environment of CPD for the trainers, for instance, and make sure that everybody profits from the energy we put in it?
Yeah, I think there are certainly several places you could start. One is just simply, no matter where you put a trainee, whether it be in a clinic or working within a hospital, that you have an understanding of how that clinic or hospital is performing. right? I think that's important. So just, looking at the quality of practice, again, the measures aren't perfect, but I think it's a good place to start. I think involving patients, through patient surveys and other sorts of things is incredibly helpful. In my clinic, we just ask patients 3 questions at the end of every visit. What did you like about your visit today? What did you dislike? What would you change? And we set that back into the system on a regular basis. Another technique people use is simply ask a patient and say, did you get everything you needed today from us? Right? These are little techniques you can use to make sure the environment in which we're embedding them is growing itself. Right? We understand that everybody's going to be at different points. What you don't want to do is be putting them into a clinic that just isn't interested in getting better, right? Or is using outmoded ways of care delivery. So that's what we're going to have to work on. Where we embed them and where we train them matters. That's number one. Number two, for those skills where faculty may be uncomfortable, and a lot of times it is things like quality, safety, breaking bad news, and other things, let's learn together. Use co-learning strategies. Brian Wong at Toronto is doing some of that, where the faculty and residents work together to solve a problem. In the process of solving a problem within the institution, they're learning the quality and safety skills they need to do that well. So I think that's a second technique. The third thing we've done is in faculty development, we actually make it a twofer. While we're teaching them to observe better, we're also helping them learn new skills. And faculty actually really like that. Because again, many of them were never taught even these frameworks around breaking bad news, informed decision making, those sorts of things. And so in the work of learning how to assess better, they actually feel like they're becoming better clinicians. We don't have proof of that yet, but that's certainly what they're telling us when we do the work. It makes sense that it's at least a reasonable place to start. But I think those are all things that you can do. The fourth is empower your residents, right? We don't use them enough as whether it be a student, a house officer, a resident, depending on your system, empower them to be part of the solution. They actually like doing this stuff. They often recognize stuff that we're doing that's kind of stupid, but we've just been doing it. It becomes a blind spot. And so the more that we can engage them and empower them, it actually reduces our work and assessment by making them self-directed. It's a skill they need for ongoing professional development, so why not learn it during the training? And they can help us improve systems. That, by the way, is the whole focus of a program we have in the States called the Clinical Learning Environment Review, where we actually visit hospitals and we do essentially an ethnography and a series of focus groups to see how the residents and fellows are being embedded into the quality and safety activities of the hospital. And then that report actually goes to the CEO of the hospital to get them to understand that this is part of their workforce and they need to be embedded in functional ways working in a functional hospital, given what Ash and Bansal and everybody has shown. So those are just some suggestions. Was that helpful? Okay.
That was a fantastic talk. I really enjoyed it. Part of me has a sort of professional bias that feels that the process of education is an apprenticeship. But you've pointed out very clearly here that if the masters aren't very good, the apprenticeships are not going to learn. The apprentices are not going to learn. But one of the things we face in a system, as we have in the UK, are the competing pressures. And you've repeatedly mentioned faculty. Our faculty, largely in the UK, are practicing physicians who are under immense pressure.
Yep.
And it's very difficult to get them to settle down, to observe, to teach. And in fact, the managers put very little value in this. I wondered about how you created the value, how you deal with the cost pressures related to education in the US, and how we might learn from that.
Yeah, I wish I had some, fantastic answers for you. I don't. We're struggling with the same thing. I think, we face similar productivity and cost pressures. Some settings have carved out time for faculty so that they can do this, so they recognize its importance, and so they're given some protected time. They're sometimes called academic half days or administrative days where they can do this. I think where other people have been successful is getting them to understand that the nature of supervision and the quality of observation affects the quality of care at the hospital. And so I think that's part of, again, the reason for the CLEAR program, to get them to recognize you can't just do this as a one-off. They're part of your workforce, and you want to make sure that they're working well, because if they don't, then the hospital and the patients are going to suffer. And now in the States, for example, readmissions come with financial penalties. So there's a real incentive for the hospital to work with educational programs, for example, to make sure that discharge process goes effectively. And there's actually some wonderful assessments around discharge that you can actually, again, make this a twofer with the institution and education around the quality discharge. It's Eric Coleman's work called the Care Transitions Measure. I had my residents call patients 3 days after discharge and ask them 3 questions. If they answer strongly disagree to all 3, the risk of readmission in 30 days is 42%. So look for synergies. This is where I think bringing the education and quality worlds together can be helpful. Because right now, many of our administrators just see education as like, oh, you're just educating. No. They're caring for patients. They're caring as part of your health system. And so these two are not separate. I think the more we get them to understand the importance of that overlap, it'll help. But we're struggling, and it varies by program. So I wish I had easy answers for you, but I think those are 2 kind of techniques, or at least approaches we use to get buy-in. Yeah.
Thanks very much. It was a great talk. Top of the Dreyfus scale. It's along the lines, I guess, of the last one. What worries me and maybe depresses me a little bit at the end of a career rather than the start is we have now 25 years of really hammering the importance of communication in the undergraduate curriculum. Where do we fit in? Breaking bad news. How do you start to orientate towards that, etc. And trying to bring in those features on Mary's non-checklist at the end of line care into professional learning. And yet, we still hear the same statistics. More than 80% of complaints around poor communication. I bet everyone in this room could recall a scenario similar to yours at Mary's. So have we impacted on that big system constraint in any way with everything that we've tried to do? So are you keeping the faith? Do you feel merging educational and clinical outcomes is the way, is going from numbers to words and numbers, as Case is suggesting in assessment? Is it going to fulfill what we want, what we need?
I think it's a fair question, Sean. I'm certainly more optimistic now. Just so everybody knows, I'm a pejorist by nature. You guys know what a pejorist is? There's somebody who thinks things are pretty bad, but they can actually get worse, right? But I think it feels like we might, you never know until afterwards, right? But I feel like we might be in a tipping point by bringing together, beginning to move away from this either or and this intense focus on one thing or the other, programmatic assessment, beginning to use more narrative, really paying attention to clinical outcomes and how they relate. I think the measurement fields have advanced more than they were 30 years ago to make this more possible, right? When you look at the quality measure field, the world I originally came from, it was pretty Spartan, 30 years ago. The measures were mostly process and structure, and they were pretty crude. We're in a better place now. It's not to say we're there, but now you have prompts coming online. So I think there's a lot of opportunity here. I think we also have to forget that, things actually have gotten better in some ways. You look at some of the communication studies, there has been some movement. It's just been painfully slow. But that's not to say there isn't movement. And so I think the other thing, getting to your point, is it's one thing to teach it and to build the capability, but if they don't go out and experience it in the workspace, it is quickly undone. Fred Hafferty talked about this in professionalism over 20 years ago, the hidden curriculum problem. We're now seeing the exact same thing play out with clinical skills. And so this variability problem is something we're going to have to tackle. And I think one of the ways to do that is to bring the clinical quality worlds and the educational worlds closer together so we can keep those in our both of our viewfinders instead of one versus the other. Because it forces you to look at what's happening with the patient in front of you instead of adjusting them out. Right? No. If they didn't get what they needed, let's explore why that didn't happen. So this is why patient-centeredness, I think, actually aligns quite well with learner-centeredness if we overlap them effectively. Did that help? Okay. John.
John Cookson, thanks so much indeed. Very, very helpful. Picking up on some of the other things in the conference, we've spent a lot of time thinking that we don't count what counts.
Yeah, Einstein.
And I think we've got some ideas about that, but they look resource intensive. and resources are finite. So the question is, what can we stop doing to make more resources?
Yeah, I think that's a really great question. I mean, I think one of the things we know that creates inefficiencies, ironically, is poor care. So, I think looking at the quality, so I'll give an example. We looked at our diabetes care at Yale, this is about 15 years ago, and we looked at our immunization rates and how well the blood pressure is controlled, and we were doing horribly. I think our pneumovax rate was like 16%, our flu vaccine rate was 10%. So I presented this data to the faculty and to the residents. And how many people are familiar with Kubler-Ross's stages of grief? Okay, good. So where do you think the faculty were?
Denial.
Yeah, exactly, yeah. And where do you think the residents were? They were in depression. Oh, Dr. Holmboe, that's awful, we have to fix that. So when we looked at that data, one of the big complaints of the faculty in denial is that we were taking care of mostly poorer folks in the clinic. And they said, well, they never show up for their visits, so how are we going to take care of them? Like, well, no, here's the thing. They actually show up 7 times on average in the course of a year. They're in our clinic every 7 weeks. That's incredibly inefficient. That is eating up your time that you can't do other stuff because they're in the clinics more than they need to be because we're not doing a good job of caring for them. So if we can improve care, then we can create space to do some other stuff, right? So that's the irony. Many times our care processes are so inefficient that it eats up the time that could be used for something else. So that's just an example where very simple interventions led to much improvement, and actually faculty felt better about what they were doing. That's number one. I think other things is don't do assessments that don't have utility. I'll give an example of something we stopped doing, and we do this a lot in the States. This has been one of the errors people made with the milestones. They take that long list and they turn it into a checklist and expect faculty to fill out that entire thing even if they've only spent a week with the trainee. That is not a good use of their time. Please stop doing that, right? And that's what we tell them. What we've done in the States, we now have several mobile apps. All we ask the faculty to do is, like when you just spent 5 minutes with the trainee, dictate in what you saw. So we have an app called Medical Mobile Milestones developed at UNC. The faculty dictate in what they saw. Natural language processing converts it to text. And all they got to do is tag it. Oh, this is the competency, I watched it, done. Right? And they say, I can do that. In other words, align the assessment task with what that person's role is in the educational system and don't have them do a bunch of stuff that just isn't useful. Like fill out a long evaluation form at the end of 2 to 3 weeks so they don't even remember most of what happened. We need to stop doing stuff like that and really take more of these aliquots of observation and make it easy for them to do. And I'm actually really optimistic. Some of the apps I see coming out now are really cool. And they've made it much easier for faculty. So those are just a couple ideas that come to mind. Was that helpful?
Yeah, thank you.
Okay.
Any other questions at all? You've got to run. Right to the back.
Thank you for an excellent presentation. You mentioned right at the start that, well, about a third of the way in, about Atul Gawande's work about the problem that the nurses could have provided that. And then you have talked quite a lot since about the faculty doing the assessment. Yep. I just wondered how you saw the future of intraprofessional assessment, and if you're building that in at what we would call an undergraduate level, or whether you think that it's more appropriate at a resident level, and just how you see the changes in the future for that.
Yeah, I think it's actually incredibly important. And I apologize. When I say faculty, I think very broadly about who faculty are. It's not just physicians or I'm a dentist. I think that's part of why I called out those other competencies, that the word interprofessionalism, again, didn't exist when I was a resident, right? In fact, I used to run this exercise with my resident at the start of every rotation. I say, all right, let's talk about who your team's going to be this month. And you go like, well, it's you, Dr. Holmboe, you're on the team. Yeah, I'm on the team. And then we got Joe, the intern. Yeah, Joe's on the team. And then we got 2 medical students. Who else? I think that's pretty much it, right? So they don't understand that there's all these other people. So I'm a big fan of multi-source feedback. I think it has tremendous utility. Like anything, it has to be done well. It's got to be done efficiently. But you can't say that you're going to be in an interprofessional world if you don't ask the people around you how you're doing. Again, you need systems to do that, but I think this has to start early. but it has to have a receptor site. Just like what I talked about with regard to communication skills. I can do a great job of teaching medical students how to do that, but if they go out and nobody lets them do that, oh, we don't have time for that. It's often a refrain heard from residents to an intern. Oh, you don't have time to take a history like just do this. The same thing with interprofessional. We have interprofessional education has to translate into interprofessional care. And that's what they have to experience. So I think that's a real challenge. We're struggling with it. But you have one of the world's gurus sitting here in London by the name of Scott Reeves, who has done wonderful work, and I certainly tap into on a regular basis. So, yeah.
Paul, you get the last question.
Thanks for a lovely talk. I was just going to follow up on Jean's point, this idea that we've got all these stressed clinicians that don't have time to do this, but it sounds like you've done a lot of work in making that more of a win-win and finding ways that clinical encounters can be educational without taking up huge amounts of time. I just wondered if you'd share some of the ways you've made that work.
Yeah, I mean, I think partly is get people to understand that even small aliquots or biopsies are still valuable. It's